If you're over 60 and you take a beta blocker every morning for your blood pressure, maybe metoprolol, atenolol, or bisoprolol, and you're still waking up exhausted, gaining weight without changing your diet or getting out of breath from just one flight of stairs, then you really need to hear this. Your blood pressure numbers might look fine on paper, but that doesn't mean everything is okay. Back in 2005, a major study published in The Lancet followed about 19,000 patients. The results were so clear that the trial was actually stopped early. People taking atenolol had significantly more strokes and higher overall mortality compared to people on other types of blood pressure medication. After that, the UK's official prescribing guidelines moved beta blockers off the first-line recommendation entirely, and that was 20 years ago. Yet millions of prescriptions still haven't caught up. In the next few minutes, I'm going to show you exactly what that trial found, what the evidence says about other options, and the 5 specific questions you can take to your doctor that might actually change your prescription. Make sure you save this video before your next appointment. Now, before we dive into the data, there's one important point, and this really matters for you. If your prescription is for heart failure, a previous heart attack, or a diagnosed arrhythmia, beta blockers can be life-saving, and today's conversation doesn't apply to you. What we're looking at here is a much narrower and much more common situation. Adults whose only diagnosis is high blood pressure. If that's you, stick with me because the research is very clear and the implications could be significant. Beta blockers have been prescribed for blood pressure for over 50 years. You might know them by their generic names Metoprolol, Atenolol, Bisoprolol, or by brand names like Elresser, Toprol, and Tenor. They're cheap, familiar to doctors, and yes, they do lower your blood pressure numbers. Here's how they work. Your heart has receptors. Think of them like little locks. Adrenaline is the key. When it connects, your heart beats faster and harder. Beta blockers sit in those locks, so adrenaline can't get in. That slows your heart rate, reduces the force of each beat, and brings your blood pressure down. For 5 decades, that mechanism made them the default choice. But the question researchers have been asking since the early 2000s is this: does lowering the number on your blood pressure cuff actually give the same protection against strokes, heart attacks, and death as the newer alternatives? For older adults with uncomplicated high blood pressure, the evidence says probably not. Before we get into the trial that changed everything, let me ask you a question most people never even think to ask. If the evidence against beta blockers for blood pressure was already building through the 1990s, why are so many people still on them in 2025? The answer isn't some conspiracy, it's inertia, and it's a well-documented pattern in medicine. Beta blockers became the default starting point back in the 1960s and 70s when they really were the best option available. By the time the Lancet trial came out in 2005, the drug was already deeply embedded in prescribing habits, in medical school teaching, and in institutional protocols. Changing guidelines is slow, changing the habits of individual doctors even slower. And here's another reason why beta blockers stuck around. They're cheap, off-patent, and familiar. So there was no big commercial push from any drug company to get doctors to reconsider. On top of that, most patients don't feel anything dramatic when they're on a beta blocker. The fatigue sneaks in slowly, the weight gain is subtle, and a doctor looking at a normal blood pressure reading has no obvious signal that something's off. This is the gap between what the evidence says and what the prescription says. It's not rare in medicine, and it's exactly why an informed patient asking the right questions at the right appointment can make a real difference. The study that really shifted the conversation is called the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet in 2005. Here's an important nuance you need to understand. The primary endpoint of the trial, non-fatal heart attack and fatal coronary heart disease, showed a 10% reduction in the emlatipine group, but this did not reach statistical significance. The trial was stopped early before enough primary events had happened to confirm that result. The stroke reduction and mortality data, however, are solid and pre-specified. So the primary heart attack endpoint was a strong trend, not a confirmed result. That distinction matters. It's important to be honest about what the data actually shows. One more piece of data from Ascot that's directly relevant to this age group. Of the 14-120 patients without diabetes at the start, 567 in the amyloid group developed diabetes over the study period compared to 79.99 in the Atenolol group. That's a 34% lower risk of developing diabetes in the amyloid group. And the story didn't end in 2005. At 16 years of follow-up in the Ascot Legacy study, the incidence rate of stroke was 0.113 per 100 person years in the amlopine-based group versus 0.18 in the Atenolol-based group. That's a statistically significant difference, and it persisted for more than a decade after the trial ended. It's fair to note that Ascot received primary funding from Pfizer, the manufacturer of amlodipine. That's a legitimate limitation, and you should know it. The good news is that the findings have been confirmed by independent follow-up data 16 years later, and they're reflected in guideline changes made by organizations with no financial stake in the outcome. If this is the first time you've heard about these results, hit the like button. It tells me that evidence-based content like this is useful and worth making more of. Following Ascot and related evidence, the UK guideline recommended that beta blockers should no longer be the preferred first treatment for high blood pressure, moving them down to fourth-line therapy. That change has stayed in place through the most recent NICE guideline update in November 2023. It's worth noting that the 2023 European Society of Hypertension guideline took a different position. They argued that the overall drop in blood pressure matters more than the drug class, and they reinstated beta blockers as a first-line option. So this is still an active debate between major guidelines. The UK NICE position, which I've been focusing on here, keeps beta blockers at step 4. Here's something your doctor might never have told you. If you're taking a beta blocker for blood pressure and your blood sugar has been creeping up, the medication itself could be a factor. The Ascot diabetes finding wasn't an isolated result. A meta-analysis published in the American Journal of Cardiology looked at data from 92 patients across 12 randomized controlled trials. It found that beta blocker therapy was linked to a 22% higher risk of developing type 2 diabetes compared to other blood pressure medications. The risk was especially high for people over 60 and for those with pre-existing metabolic risk factors like elevated fasting blood sugar or a higher BMI. Here's how it works. Beta blockers suppress insulin release from the pancreas. At the same time, they dull the early warning signs of low blood sugar, the shakiness, the sweating, the racing heart that would normally tell you something's wrong. So the drug does two things at once. It suppresses insulin and it masks the signals your body normally uses to alert you. If you're over 60, carry a bit of extra weight around your middle, and have been told your blood sugar is borderline, your blood pressure medication could be pushing that number in the wrong direction. Diabetes itself is one of the strongest risk factors for heart disease and stroke. So a medication that's meant to protect your heart, but at the same time raises your risk for diabetes creates a real tension. And it's something you absolutely should discuss with your doctor. One important distinction, most of the clinical trials showing this diabetes risk used Atenolol. Newer vasodilating beta blockers like carvedilol and nebivolol have a different metabolic profile. If you're on a newer beta blocker, the metabolic picture is a lot more nuanced. And here's something your doctor almost certainly didn't mention. Beta blockers work by capping how high your heart rate can go. That mechanism, the way beta blockers cap your heart rate, is exactly what lowers blood pressure. But your heart rate is also the primary dial your body uses when it needs more oxygen during physical activity. When that dial has an artificial ceiling, exercise doesn't just feel harder. It actually is harder in a measurable, documented way. Published evidence shows that beta blockers reduce both exercise, heart rate, and V2 max. That's your body's maximum capacity to use oxygen, and it's the single best objective measure of cardiovascular fitness and long-term health. For example, a person whose heart rate should reach 130 beats per minute during exertion might find it capped at 100 on a beta blocker. That 30-beat gap is the difference between a comfortable walk, feeling easy, and feeling like real work. Here's what this means in practical terms for someone over 60. The usual advice to aim for 50 to 70% of your maximum heart rate during exercise doesn't work the same way anymore. Your ceiling is lower and your effort feels higher at lower workloads. There's solid evidence in cardiology journals showing reduced exercise tolerance in people with high blood pressure who are on these drugs. Now, an important clarification, the cardiovascular benefits of exercise are not eliminated. Exercise on a beta blocker is still hugely beneficial, but for some patients, that increased perceived effort becomes a real barrier to staying active. And staying active is one of the most powerful tools for managing blood pressure long term. That's a meaningful quality of life issue, and it's absolutely worth bringing up with your doctor. And if you're over 70, this next finding is the one that really sent me down a research rabbit hole because the consequences are serious. Beta blockers are among the drug classes linked to orthostatic hypotension, that brief lightheadedness or dizziness you get when you stand up from sitting or lying down. A systematic review of randomized trials confirmed that drugs working through sympathetic inhibition, including beta blockers, are associated with significantly higher odds of orthostatic hypotension compared to a placebo. For someone who's 70 or older, this isn't just uncomfortable. It's a real fall risk, and hip fractures carry serious consequences. A 2019 systematic review spanning 36 countries found that one-year mortality following a hip fracture is roughly 20 to 25%. More than half of patients don't get back to their previous mobility levels. Everything in this video is meant to give you information for a conversation with your doctor. What I'm about to say is the most important line in this entire script, and I need you to take it seriously. Never stop a beta blocker suddenly without medical supervision. Stopping abruptly can trigger a well-documented rebound effect. Your heart rate and blood pressure can spike quickly, and in some patients, this can provoke a heart attack or a dangerous arrhythmia. Any transition off the medication must be supervised by a physician and tapered gradually, usually over 4 to 8 weeks. This isn't a disclaimer. It's a clinical reality that applies to everyone watching this video. Now, here's what the guidelines actually recommend instead, and it's simpler than you might expect. The NICE guideline updated in November 2023 is very specific. For patients aged 55 and older, first-line treatment should be a calcium channel blocker. Amlodipine is the most commonly prescribed or a thiazide-type diuretic for patients under 55. An ACE inhibitor or ARB is recommended as first-line therapy. Beta blockers only come in at step 4 for resistant hypertension that hasn't responded to 3 other drug classes or for patients with a specific reason like angina. It's worth taking a moment to understand how these alternatives work. A calcium channel blocker like amlodipine relaxes the walls of your blood vessels directly. It doesn't slow your heart. Instead, it reduces the resistance your heart pumps against. Your heart rate stays at its natural level, and your exercise ceiling remains intact. The ASCOT data showed 34% fewer new cases of diabetes in the calcium channel blocker group. The 16-year legacy data confirmed that the stroke benefit persisted over time. And unlike beta blockers, calcium channel blockers have a consistently neutral or even positive metabolic profile. ACE inhibitors and ARBs, drugs like linapril, ramipril, Lortin, and candesartan work by blocking a hormonal pathway that makes blood vessels constrict and causes the body to retain sodium. They've also been shown to protect kidney function and have consistently neutral or positive effects on metabolism. For patients showing early signs of kidney disease or diabetes, these drugs are often the preferred choice precisely because of these added protective effects. One practical note, ACE inhibitors cause a persistent dry cough in about 10 to 15% of patients. If that happens, switching to an ARB achieves the same effect without the cough. Here's exactly what to do with this information. Step 1. Check whether you're taking a beta blocker specifically for blood pressure, not for heart failure, arrhythmia, or after a heart attack. The names to look for are Metoprolol, Atenolol, Bicoprolol, Propranolol, and Carvedal. Step 2. Write down 3 questions before your next appointment. Was my beta blocker prescribed for uncomplicated high blood pressure, and does that still match current guidelines? Have my fasting blood sugar and lipid panel been reviewed recently? Based on my overall health, would a calcium channel blocker or an ARB be a better option for me? Step 3. Ask for a formal medication review if you've been on the same blood pressure prescription for more than 2 or 3 years. Step 4. If your doctor recommends a transition, confirm the tapering schedule with them. A responsible reduction usually takes 4 to 8 weeks with monitoring throughout. Step 5. Keep a simple log for 3 to 4 weeks, your morning blood pressure reading, an energy rating from 1 to 10, and any dizziness when standing. Having your own data makes the conversation with your doctor far more productive. One quick question before we wrap up. Drop it in the comments. How long have you been on your current blood pressure prescription? And have you ever had a formal medication review? It takes 10 seconds and it genuinely helps me understand who this content is reaching. Before I close, one important reminder. If your prescription is for coronary artery disease, heart failure, or arrhythmia, the evidence for beta blockers is strong. But if your only diagnosis is high blood pressure, if your prescription hasn't been reviewed in years, and if fatigue, weight changes, or blood sugar trends have been creeping in the wrong direction, you now have the evidence and the exact questions to walk into your next appointment differently. The research shifted in 2005. The guidelines shifted with it. You deserve a treatment plan that is shifted with both. If someone you care about has been managing their blood pressure for years without a medication review, share this video with them. One informed conversation with a doctor armed with the right questions can genuinely change what happens next. And if you want to dive deeper into any specific part of the evidence, let me know in the